Hi, this is the first video of our Luminess series. This is the current automation instrument that we have in blood bank, and you can see that we actually have two of these instruments. They are used exactly the same way. One of them runs 24 hours a day and the other one only runs 12 hours a day. They basically work off of a hemagglutination for the ABO RH typing and solid phase or capture technology for the antibody screens and antibody panels. You can see the instruments each have a computer attached that you can actually use to, when you go to order the test and view results. Okay, there's saline and a waste container. Over here we have a bay where we put the patient samples, go in these racks, and we can put up to 5 patients in a rack, and we slide it in, and the barcode reader will pick up the barcodes on the patient samples. Over here to the right, we work off of these trays with little holders that we put strips on, and depending on what strips you select, dictates what kind of test goes in there. So these strips really have nothing in them. They're just little micro wells that they will use these strips to do ABO and RH typing. So once you always have to have 2 strips in every cassette holder. Cassette holder has to fit down on the tray into the holes that are already there. Make sure it's straight, gently slide it in, and once the instrument recognizes a tray there, it will come up, the fork will come up and pick up the cassette holder, and it'll actually scan little barcodes that are on all the strips, so it knows what kind of strip it is. It also would know if the strip was already previously used. Once we put samples in there, we would go over here, hit the running man, and tell the instrument what test we want to order. So we can use this instrument to do DATs, 3 different types of panels. We could do groups, we could do group screens, or we could just do screens by themselves. So we would select usually, or for example, we may be coming over and picking group screen. Better. And we click there, sorry, and then hit next. And at this point, if there were samples on there, the specific accession numbers would be listed there, and we would select which samples we're trying to run the test on. Then it's a fully automated instrument in that it pipettes, incubates, spins, and reads. Once the test is done, it even has its own camera that it actually takes pictures of all of the wells, and you can view them on the computer screen as well as make a printout if necessary. Come over here to this screen, you can see some results. This was just our QC from this morning, so you can see we have QC 1, 2, and 3. It's a 3 reagent QC kit. You can see it gives you the interps, and it actually has taken pictures of all of the specific wells. So again, like I said, for the type NRH, it's based on hemagglutination. So here you can see a 3+ is almost a solid agglutinate with some small agglutinates. We can also enlarge this. If we click there, we can bring it up so that we can see it better. This would be similar to what it looks like when we're used to working in tube at the bench. I can go back. You can see that a negative would be no visible agglutination. Again, just like when working in tube, the forward type and the reverse type have to be in agreement. If they're not in agreement, the interp would come up as NTD, which means no type determined, and in that case we would have to take the sample over to the bench and work in tube. It also does have 2 anti-D reagents. They call it D1 and D2. It just means that there's 2 different clones that we test each patient against. Usually they're in agreement. Occasionally you may see one of the 2 coming up positive and the other one coming up negative. but most of the time they're in agreement. If we have something where one is positive and one is negative, we interpret the patient as Rh negative, or sometimes they call them question marks. If there's question marks, we may have to take it to the bench and we run it against yet another anti-D reagent. Every patient has a monocontrol, which would be similar to what was an Rh control when we were working in tube. So everybody's monocontrol has to be negative. If your monocontrol comes up positive, it could be like a possible cause could be like if your patient has like a cold autoantibody or something like that. So everybody's monocontrol has to be negative. Otherwise, if the monocontrol comes up positive, it won't interpret your results. And again, it would have to be done in tube at the bench. The screen, like I said, is capture technology, which is solid phase. So a negative actually looks like a solid clump, but if we enlarge it, this is a negative result. So you just have to train yourself to be what in the screen looks like a positive in two up at the typing area. What looked like this would have been considered positive. When we're talking about the screen or for panels, this would be considered a negative result. So this whole area, this is a picture looking down at the microwell. This whole area at the bottom of the microwell is coated with antigens of lysed red cells. So when we add our patient plasma to these strips that have these wells that have known antigens already there. You can't see them because the red cells are lysed. You incubate using lists. It's a specific list that we use on the instrument. And then after incubation, there's washing, and they add what they're called indicator cells. And actually these red cells are actually the indicator cells that you see. So the fact that the indicator cells all went to the center of the well, which would be the lowest point of the well. If you're looking at the bottom of a test tube, how it has a rounded bottom. If the cells upon centrifugation all went to the middle, that meant they all went to the lowest point. They did not adhere to any antibodies attached to antigens outside here, as opposed to a positive reaction. This is a 4+ reaction. You can see the red cells almost form like a carpet along the whole entire bottom of the tube. So what that tells us is that we know the antigens were already present. If the antibody to any of those antigens was present, it would attach. And then when we added the indicator cells, it gives us a visible reaction. So you can see here the fact that the indicator cells were blanketing the whole bottom of that well. That's the strongest reaction you can have with capture technology. So it's just training yourself to get used to seeing what a positive looks like in capture as opposed to what a positive looks like in tube. So, anything you want to add? Yeah. And so you can see here, this QC number 3 here, you can see those all 3 screening cells. Another thing to mention here is it's a 3-cell screen. And you can see this was a patient who, was a QC, but it was a sample that had, screening cell 1, 2, and 3 were all negative. And again, it looks like a cell button in the bottom there. And if all your samples will have a positive control with this. So see, for each one, even when the screen's negative, the positive control is expected to be positive, and that was. Again, just like in tube, if you get a positive screen, we would follow up with antibody identification if necessary. And if we've detected the antibody on the instrument, then we would normally follow up with a panel on the instrument, at least our initial panel. And the panels are basically the same as the screens, except it's more, it's a full double strip. So it's it's going to occupy both spots in this carrier. 2 full strips that would be designated just toward one patient panel. You do not have the ability to do a select cell panel when you're working on the instrument. You would have to run the entire panel. Okay, that's one of the things. But again, some of the advantages of the instrumentation is it saves tech time. Somebody doesn't have to physically do all the testing. Like I said, once you load it on and tell it what to do, you can walk away and come back when your results are ready. There is a interface that will cross over the results to Cerner, so that we just have to go into Cerner and verify them. The other thing is it is good because it can be viewed at a later time. So remember, tube testing has to be read right away and then discarded. It's not like you can leave the tubes for someone to double check your work later. So then one of the nice things about the instrument also is that someone can come back in and review reactions or interps or whatever. I'm trying to think. We also, in addition to doing types and screens and panels, we can also do DATs on the instrument. But it's only going to give you the IgG DAT. So if you have to do a DAT breakdown, again, it would be done in tube for the polyspecific and the C3. And then we do daily QC, which would entail us doing a few simple tasks and running the reagent QC on there every day. Weekly, we have to shut down the instrument and back up the results to a disk. So that's another thing, is we back up all those results to a disk, and we hold those disks, you know, we can hold them indefinitely if we need to go back and check something. And then there's also monthly QC, where it's like a lengthy decontamination and cleaning of the instrument. So that can take a little bit of time, but otherwise it really greatly reduces the amount of tech time that's needed to run these instruments. All your specimens have to be anticoagulated. You can't run clotted specimens on here. You have a question? Do you want to look inside? So, okay, if you want to look inside here, you have a probe over there on the left.
I can't really see it.
No, it's too dark.
Well, we tried.
Hold on. I don't know. It's still kind of dark.
That's good.
You can see the probe in there. Goes in. It'll pipette all your samples. Pipette all your reagents. There's a wash station below it. There's an incubator in the back there. And then the centrifuge and chem are in this area behind here. Okay, that's about it.
Okay, thank you.